today's session, especially on cardiovascular system question and answer session. We'll discuss today some questions and their answers, and there are some options of answers with every question, and we'll pick up the best answers of the questions. So let us start today. This first question is now, an 18-year-old woman has a raised CRP, a rash consistent with erythema marginatum and pyrexia. However, the clinical remains uncertain about the diagnosis of the acute rheumatic fever. Rapid response to which treatment will help to confirm the diagnosis? এখন একটা ব্যাপার হলো এখানে, সেটা হলো যে rapid response to which treatment will help to confirm the diagnosis. এখানে there are some clinical features like raised CRP level. There is a rash that consists of erythema marginatum and pyrexia. There is a fever, there is erythema marginatum, there is a C-reactive protein positive, and the diagnosis of the acute rheumatic fever. But acute rheumatic fever treatment options, there are aspirin, bed rest, diuretics, glucocorticoids, and high-dose antibiotics. So which of the treatment may help the diagnosis of the acute rheumatic fever? So aspirin, first option is here is aspirin. Aspirin is very much in high doses especially, is very much effective to reduce the pain and rheumatic fever features also. It's the very much effective drug actually. When there is a response to aspirin, especially aspirin to arthritis or aspirin to the fever also, then it is certain that the diagnosis may be acute rheumatic fever, or the diagnosis is acute rheumatic fever actually. So acute rheumatic fever is very much sensitive to aspirin. So aspirin is should be the answer here. But I will discuss the other answers also. Bed rest, yes, bed rest is an important factor when there is a arthritis as well as there is a carditis. So if patients suffering from carditis as well as heart failure, so in that cases bed rest is very much important. And if patients suffering from arthritis also, so bed rest is important also in that cases. But diuretics, actually we don't use diuretics if there is not actually mitral regurgitation of the patients developed due to rheumatic fever, and there is a mitral valve involvement, there is mitral regurgitation, and there is so much regurgitation that patient develop shortness of breath, and there is volume overload. So in that cases, we may use diuretics. Otherwise, diuretics is not actually used. And glucocorticoids, yes, that is the steroid, and the steroid is used in case of arthritis as well as when there is a carditis also. Severe arthritis that not responding to respond to the NSAID especially, in that cases we use glucocorticoids or steroid. And when there is a carditis, then in that cases even maybe myocarditis or endocarditis or pericarditis, glucocorticoids by steroid is very much needed in that cases. And high-dose antibiotics actually is not needed, as we know that acute rheumatic fever, though it follows the pharyngitis, and we usually use antibiotics, but acute rheumatic fever condition is not an just organism-directed injury to the tissues. Actually, it is an autoimmune reactions, and this is the actually antigen antibody reactions or cross-reactivity also it is called. So as there is a cross-reaction, an immunological reaction is involved here. So there is a minimum role of high-dose antibiotics, especially at these cases. But we usually use antibiotics, especially penicillin, or if patient is sensitive to penicillin, in that cases actually erythromycin is used as an antibiotic to control the infection, especially to control the sore throat, and also to control the actually severity of the acute rheumatic fever also. And also this steroid is used to prevent the rheumatic fever also, and to rheumatic fever recurrence also. So high-dose antibiotics is not the appropriate answer here. So steroid is not appropriate answer here. Diuretics, bed rest, no. Aspirin actually is the appropriate answer here. And if patient is responding to aspirin, in that cases, we actually get sure that this patient is suffering from acute rheumatic fever. So the answer of this question is here, aspirin is the, and among the NSAID, actually aspirin is the very much sensitive drug to the acute rheumatic fever. And other NSAID actually don't have so much impact on the treatment or the on the acute rheumatic fever actually. So if we go through the literature or some discussions here, there's the management of the acute rheumatic fever. When actually the management of acute rheumatic fever, there is a single dose of benzyl penicillin or oral phenoxymethyl penicillin for the 10 days. If patient is allergic to penicillin, erythromycin or cephalosporin can be given. We already discussed. And analgesia, or to reduce the pain actually in the arthritic pain, usually we achieve with high dose of salicylates, that is aspirin. Usually we use high dose of salicylates. And treatment is then directed towards the limiting the cardiac damage if the patient actually has got any type of carditis in the form of endocarditis, myocarditis, or pericarditis. Then you use the actually target specific treatment in that cases, and relieving symptoms also. So about the aspirin, here it said that relieve the symptoms of arthritis rapidly and a response within 24 hours helps to confirm the diagnosis. So this is the answer actually of the first question here actually. And in steroid, actually a more rapid symptomatic relief than aspirin are indicated in case of carditis or severe arthritis. In case of carditis, usually we use steroid, and when there is a severe arthritis, actually, when there is a severe arthritis actually, and when it is not responding to the NSAID, in that case, it's actually steroid is used. So I think aspirin is the answer of this question here. So now we move to the second question. A 66 years old male with a 75 pack year history of smoking is admitted within a 2-hour history of central crushing chest pain radiating to his jaw. That is, the patient has got, this is the acute coronary syndrome type of chest pain, and it radiates to the jaw. ECG reveals ST depression in 2-3 ABF. There is ST segment depression. 6-hour troponin I was 450 nanogram per liter. That is very much positive. Grace score reveals 6-month mortality of 9%. This is Grace score showed this actually indicates the mortality ratio 9%. The patient was started on tirofiban, was waiting for angiogram. So before doing angiogram, and or when the patient is waiting for being shifted into the cath lab, he was given a tirofiban. What is tirofiban? Tirofiban actually as an antiplatelet drug. And what is the mechanism of action of tirofiban? So here the question wants to know the mechanism of action of the tirofiban. Actually, we all know that tirofiban is an antiplatelet drug, and there are some antiplatelet drugs, and they actually act in different or various ways to some inhibit the platelets activation, some inhibit the addition of the platelets to the surface actually, that prevents the progression of the platelet activity also. So there are several mechanisms of action of the antiplatelet drug. That some are acting on the ADP receptor antagonist, some are factor 10A inhibitors. Actually, these are the anticoagulants actually, and the GP2V3A inhibitor, and actually GP2V3A inhibitor. These are the drugs actually that inhibits the platelet aggregation actually. That COX inhibitor, this is the some drugs, especially a spin group of drugs that are COX inhibitor, and direct thrombin inhibitor that are actually not antiplatelets. These are actually the mechanism of action of the anticoagulants. So among these 5 answers, the factor 8 inhibitor, factor 10A inhibitor, and dendritic thrombin inhibitor. These are actually the mechanism of action of the anticoagulants. And the three, other than these two mechanism of actions, the rest three mechanism of actions like ADP receptor antagonist, factor 10A inhibitor, and COX inhibitor. These are the three ways of mechanism of actions. Usually, that are the mechanism of action of the antiplatelet drugs. But there are several types of antiplatelet drugs that act on the different pathways or the different actually the parts of the platelet aggregation pathway. So the Trophibon is a one group of drug. Actually, this is the actually Apixaban or Trophibon. These are the group of drugs that actually inhibit the GP2B3A inhibitor. So GP2B3A inhibitor, this is the drug that actually this is the answer. Actually, this is the by this inhibition of the GP2B3A, actually Trophibon acts. So this is the answer here. That is a C, GP2B3A inhibitor. This is the mechanism of action of the Trophibon. If we see here the actually the thrombus formation or the platelet aggregation or platelet stimulation, there's platelet activation. There are several mechanism here, and there are some receptor actually blocker like ticlopidine, clopidogrel, prasugrel, ticagrelor. This is a P2Y12 receptor blocker. There are some platelet aggregation inhibitor. That is Apixaban, eftifibatide, tirofiban. These are the group of drugs actually that acts on the glycoprotein 2B3A complex receptor. This is the actually the glycoprotein 2B3A receptor blocker. So they inhibit the platelet aggregation. And aspirin actually they inhibit the COX-1 enzyme, and that actually acts within the platelet actually. So this is the so there are some actually blocks the receptor, some actually receptor on the platelets surface, some blocks the glycoprotein 2B3A receptors, and some acts on the COX enzyme within the platelets actually. So there are several ways of mechanism by which the antiplatelets actually works. So this is the answer here. The answer is that glycoprotein 2B3A receptor blocker. So in this question, the answer is glycoprotein 2B3A receptor blocker or inhibitors. So this is the actually another picture that depicts the different ways of action of the antiplatelets in different sites. Some have aggregation inhibitors like glycoprotein 2B3A inhibitors, Apixaban, eftifibatide, and Trophibon. There are some monoclonal antibodies also that inhibits the glycoprotein 6 inhibitors and the glycoprotein 1A2A inhibitors. There are some drugs. And there are some drugs also acting on the within the platelets also, COX-1 inhibitor, and some are also acting on the surface receptor, or and especially ADP P2Y12 receptor antagonists like ticlopidine, clopidogrel, prasugrel, cangrelor, or ticagrelor actually. This is the antiplatelet drug actually. Now we move to the next question. A 34-year-old woman presents with symptoms of breathlessness on exertion, a malar flush, and has a past history of rheumatic fever. So this patient has history of rheumatic fever, as well as this patient has the features of breathlessness on exertion and a malar flush. So a malar flush is some actually, these are some indicative of mitral stenosis also. And the patient is in sinus rhythm and has an echocardiograph confirms that the patient has got actually mitral stenosis. Which physical sign is she likely to have? So there are 5 options, and a patient suffering from mitral stenosis may have a lot of symptoms and signs, but the 5 symptoms, the 5 sign actually described here. So we have to pick up the best answer among these 5 options. So there is ejection systolic murmur. We all know that The murmur in mitral stenosis is the mid-diastolic murmur. We all know that the murmur is described as there is the rough rumbling mid-diastolic murmur, best heard in the bell of the stethoscope, patient in left atrial position, breath hold in expiration, and actually this is the way patient is left atrial. These are some some features usually we described during the description of the mitral stenosis. So ejection systolic murmur, this is not actually true in that actually a patient, if suffering from mitral stenosis, usually he or she have mid-diastolic murmur. Actually, that is diastolic murmur, or actually the mid-systolic click, that is mid-systolic click, not the answer here. There is pre-systolic accentuation. Yes, why this pre-systolic accentuation? And before because this pre-systolic accentuation due to atrial systole, as patient is in sinus rhythm, so he is her atrium is active, so her atrium contracts. So this atrium, when the atrium contracts, we all know that at the end of diastole, or before the actually end of diastole, there is pre-systole that is actually performed by the contraction of the atrium. And this atrium contraction, this contributes to around 30% of the total end diastolic volume of the left or right ventricle when there is a contraction of the left or right atrium. So this causes pre-systolic accentuation, and there may quiet second heart sound. Quiet second heart sound is usually found in case of mitral regurgitation and thrusting apex beat. Actually, thrusting apex beat is not found in the case of mitral stenosis. Usually, we see tapping type of apex beat in a patient suffering from mitral stenosis. So, among these 5 answers, C is correct here. This is pre-systolic accentuation. So there are actually a lot of features found in the mitral stenosis, but among these 5, pre-systolic accentuation actually this is actually the features of mitral stenosis, and the other features actually not correlates with the mitral stenosis. This actually features of the other valvular heart disease. Here we see that mid-systolic rumbling with pre-systolic accentuation actually when the patient is in sinus rhythm. So this is the answer actually. If patient suffering from mitral stenosis and he or she if he is in sinus rhythm, then we actually found pre-systolic accentuation along with mid-diastolic murmur. So the answer is C here, pre-systolic accentuation. And now we move to the next question. An 80-year-old man presents with an incidental ejection systolic murmur. So during examination, somehow in a patient with 18 years old was found that he had ejection systolic murmur. His family physician notices a parasternal thrill. So the physician who examined him, he got a parasternal thrill as well as maybe a parasternal murmur also. What is the likely underlying reason for this thrill? So there is actually a tricks in the question here. So a patient, if so which of the following 5 options has got ejection systolic murmur as well as the right parasternal thrill? So aortic stenosis. A patient with aortic stenosis, we all know that has got ejection systolic murmur, and a patient have aortic stenosis also has the right parasternal murmur or thrill also. And large atrial septal defect, this patient actually don't have any ejection systolic murmur or parasternal thrill. Mitral stenosis, we usually get the mid-diastolic murmur. But in case of pulmonary hypertension, usually we don't get ejection systolic murmur, but if the patient suffering from pulmonary regurgitation. So like that, we may get early diastolic murmur of the pulmonary regurgitation and right ventricular hypertrophy. Actually, due to right ventricular hypertrophy, we don't get any thrill actually, pedestrian thrill. Actually, we get thrill if there is a actually valvular heart disease or type of stenotic, especially the ejection systolic murmur, we get usually get in aortic stenosis. So the aortic stenosis is the answer here. So here with the right second intercostal space, that is the aortic area. The aortic stenosis murmur is best heard in this area. In the left second intercostal space is the pulmonic area. This is the pulmonary stenosis murmur is best heard here. The right ventricular area or the left lower sternal area. And this is the area where actually we get tricuspid regurgitation, aortic regurgitation murmur or VSD murmur here. And it is the apex, and usually we get mitral stenosis or murmur or mitral regurgitation murmur. Mitral stenosis murmur is the diastolic murmur, and mitral regurgitation murmur is the systolic murmur. Usually we get here, and usually mitral stenosis murmur is the localized, and mitral regurgitation murmur has got there is some radiation. Actually, this radiation goes into the axilla, or that may goes into the back also. So actually, these are the places where usually we get different types of murmur or originated from the different types of valves actually. So this is the site where there is a stenotic or regurgitation murmur usually we found. Actually, when how we feel the thrill or thrill, actually we feel thrill by base of the fingers. Here is a thrill, base of the fingers, and by tip of the fingers, actually fingertips, we feel pulsations, and by base of the hand, actually we feel hips, like parasternal hip, and this is the actually different parts of the hands that is used to feel the different types of actually pulsations, like thrill hips are usually felt. This is the features of aortic stenosis murmur. This aortic stenosis murmur is the best heard in the second right intercostal space, and the murmur is character harsh, and usually is the timing is the ejection systolic murmur. The ejection systolic murmur is the consistent with aortic stenosis actually. And the aortic stenosis murmur actually is a best heard in the parasternal second right intercostal space. There is radiation into the carotids, and there is maybe perception of ejection clip also. And the murmur is the harsh crescendo decrescendo systolic ejection murmur usually we found. So now we move to the another questions. A 17-year-old female presents with recurrent attacks of collapse. These episodes typically occur without warning and have occurred whilst she was running for a bus. There is no significant past medical history, and the only family history of note is that her father died suddenly when he was 30 years old. What is the likely cause here? So a 70-year-old female presents recurrent attacks of collapse. That is, patient goes into recurrent attacks of actually syncope. So patient is suffering from syncope, and also this lady has got history of family, positive family history, like his father has got died from the suddenly when he was 38 years old. That is, he had this disease is running in the family. So what is the likely cause? Vasovagal attacks. We all know that vasovagal attacks usually not in the run in the family, as well as that doesn't consistent with the recurrent attacks of collapse. And usually it doesn't happen when there is exertion. Actually, this young lady experiences these types of syncope when she was in on exertion. Actually, the exertional syncope, this is the actual features of cardiogenic syncope. Actually, this is the important features when patient experience syncope when he or she is in exertion. It is usually suggests this patient may have cardiogenic syncope other than other causes of syncope. So these are the vasovagal attacks, anxiety, epilepsy, malingering. No, malingering is not possible here. Epilepsy doesn't occur when a patient is in exertion. Anxiety and vasovagal attacks. Actually, this is not consistent with the actually a syncope during the exertion. And only the cardiogenic syncope, that is if a patient has structural heart disease like aortic stenosis or hypertrophic obstructive cardiomyopathy or pulmonary stenosis. This type of features actually when there is obstruction and severe obstruction on the outflow tract, in that cases usually patient experiences this type of actually syncope when he is on exertion. So cardiogenic syncope, that may be due to structural heart disease, and this structural heart disease may be due to aortic stenosis or hypertrophic obstructive cardiomyopathy, or maybe due to pulmonary stenosis also. So this type of obstructive type of lesions in the outflow tract can cause the cardiogenic syncope actually. So this should be the answer here. That is D, cardiogenic syncope. So here we see that different causes and classification of the TLOC, means transient loss of consciousness. That is the consistent with the syncope actually. So there may be non-traumatic cause, there may be traumatic cause, there may be head trauma and patient may have transient loss of consciousness. Other than the head trauma, there may be some non-traumatic cause, and the non-traumatic cause may be due to sudden transient loss, may be due to syncope, maybe epileptic features, maybe psychogenic cause, then maybe some other rare causes. And the syncope actually, there may be reflex type of syncope, there may be orthostatic type of syncope, and then maybe cardiac syncope. And reflex syncope are also called vasovagal reflex, vasovagal cause. And epileptic seizures, there may be some general tonic-clonic or tonic-clonic seizures of epilepsy, and is actually this is the another chapter. So there is a transient loss of consciousness, but usually doesn't occur with the exertion actually. So there is no association of the exertion with the epilepsy. A patient may have psychogenic cause, there is or malingering cause. In that cases, usually patient, this syncope doesn't occur with the exertion actually. And then maybe some other rare causes like cyanotic breath, like a patient if suffering from the cough actually petrology failure, or if patient suffering from subarachnoid hemorrhage, or TIA, especially vertebro-basilar TIA or subclavian stool syndrome, this patient may experience transient loss of consciousness, but this is not consistent with the syncope actually. We actually call syncope is that when there is a transient loss of consciousness due to cerebral hypoperfusion, and this cerebral hypoperfusion is due to the some causes, and this actually most of the causes are related to the cardiac causes actually, and there may be also some vasovagal cause, or there may be some orthostatic hypotension. So there are actually different when a patient suffering from syncope. So how actually we approach to a patient having syncope. So this is the way how we approach to a patient having syncope. And syncope means actually the cerebral hypoperfusion. This is the cerebral hypoperfusion patient gets transient loss of consciousness, and this transient loss of consciousness actually occur due to cerebral hypoperfusion, and this cerebral hypoperfusion occurs due to actually cardiac or heart is involved here. So this heart involved may be due to vasovagal, or there may be orthostatic hypotension, or there may be some structural, or there may be arrhythmia cause of the heart, structural heart disease like hypertrophic obstructive cardiomyopathy, or aortic stenosis, or pulmonary stenosis. Or this patient may have some arrhythmogenic cause, like arrhythmia cause like ventricular tachycardia, ventricular fibrillations, or maybe atrial fibrillation with false ventricular rate, or maybe patient may have supraventricular tachycardia also, that can cause to the having transient loss of consciousness, that is cerebral hypoperfusion, that is syncope. So this is the way actually a patient gets syncope. And after getting syncope, usually patient fall down And when we keep the patient in the lying down position, in that cases, actually perfusion to the brain develops, and patient gets actually regain his or her consciousness. So this is the way actually a syncope usually occurs in a person. So these are the common causes of syncope, like cardiovascular syncope, structural heart disease, or arrhythmia. There may be orthostatic hypotension, autonomic nervous system failure, and this may be occurs due to long-standing uncontrolled diabetes mellitus that may lead to the development of autonomic neuropathy, and this autonomic neuropathy may cause orthostatic hypotension, and there may be drug-induced. There are some drugs that can cause the vasodilatation and cause orthostatic hypotension. Even if the patient has got dehydration, and age dehydration may also cause the orthostatic hypotension also. And there may be some neurally mediated, that is reflex syncope or vasovagal syncope, and this is the vasovagal syncope, or if there is a carotid sinus syndrome. If there is carotid sinus is very much sensitive to pressure, then he or she may go into the syncope due to pressure over the carotid sinus. And there may be some psychogenic causes also. So this is the approach. Another approach, how actually we approach to a patient having syncope actually, and we can also differentiate a patient having syncope or seizure also. And we can also reach a diagnosis either to find out the causes of syncope of the patient. So now we move to the another question. A 43-year-old man undergoes a routine health checkup with his employers. He is found to have a murmur, isolated systolic hypertension, 180/60 millimeter mercury, and there is left ventricular hypertrophy on his ECG. A significant regurgitant blood flow is noticed across the aortic valve on echocardiogram. Which of the following clinical signs is likely to be observed? So there are five options given here, and we have to find out the appropriate answers among these five responses actually. So there is maybe crescendo, decrescendo murmur, palpable thrill in the aortic area, prominent pulsation in the neck, that is the Masser sign, quiet second heart sound, and slow rising pulse. So among these five answers, which one is the best fit to the scenario that is described here? So we again go through the scenario. A 43-year-old man undergo a routine health checkup with his employers. So there is a routine health checkup. Actually, in that patient doesn't have any symptoms. So patient is asymptomatic. He is found to have a murmur. So during examination, he is found to have a murmur. Isolated systolic hypertension. Here we see that systolic pressure 180 and diastolic 60. So there is a wide pulse pressure. So we have to know what are the causes of wide pulse pressure. So aortic regurgitation is a cause of the wide pulse pressure. As aortic regurgitation can cause the murmur and wide pulse pressure, and also aortic regurgitation can cause the volume overload of the left ventricle, and this volume overload of the left ventricle can cause the left ventricular hypertrophy, and it may get on the ECG also. So there may be features of left ventricular hypertrophy on the ECG, and a significant regenerative blood flow is noticed. So during echocardiography and color Doppler study, there is a regurgitation. So actually, these are the regurgitation type of murmur also. So that actually concerns with the aortic regurgitation. So which of the following clinical signs likely to observe? The crescendo decrescendo murmur. Already some few minutes ago, we described that aortic stenosis murmur has got crescendo decrescendo type. So this is not the features of aortic regurgitation. These are the features of aortic stenosis. But the findings from the above scenario, we suspect this patient may have aortic regurgitation. So we have to find out the features that consistent with the aortic regurgitation. So palpable thrill in the aortic area is yes. The palpable thrill in the aortic area is usually found in case of aortic stenosis. So this is not the answer. There's prominent pulsation in the neck, that is DMASER sign. We all know that in the patient suffering from aortic regurgitation, a patient may have there is some peripheral signs like DMASER signs, and there is a Durosa's sign. There is a DMASER, that's head nodding. Durosa's sign, Corrigan sign. There are a lot of peripheral signs actually we may get in a patient suffering from aortic regurgitation. So if, as we suspect, this is maybe a case of aortic regurgitation, and this is the DMASER sign is a peripheral sign of the aortic regurgitation. So this is the answer, I think, appropriate answer here. There is a prominent pulsation in the neck, that is DMASER sign. There is quiet second heart sound, maybe the features of aortic regurgitation, and slow rising pulse, usually a slow rising pulse, also a feature of the aortic stenosis. So among these 5 features, this C is the most appropriate to correlate with the answer of the aortic regurgitation. That is prominent pulsation in the neck that causes DMASER sign. Here we see that there are several features of aortic regurgitation, physical findings like Durosa's sign, and there is a several murmur like early diastolic murmur at the base, and also there is a wide pulse pressure. There is a difference between systolic and diastolic is more than 50% of the systolic pressure. So the wide pulse pressure, and also we see from this case scenario that there is a wide pulse pressure. This is around the 180 minus 60, that is 120 millimeter mercury pulse pressure, and 180 millimeter half is 90, and 120 is more than 90. That is, it is more than half of the systolic pressure actually. Wide pulse pressure and special findings maybe cardiomegaly. And here we describe the different peripheral signs of a patient having aortic regurgitation. There is DMASER sign, Muller sign, Becker sign, Quincke sign, Durosa's sign, Trove sign, Manny sign, Hill sign, Rosenbach sign, and Gerhardt sign. So these are the several signs usually we get in the peripheral vessels, maybe in the carotid artery, maybe in the nail, this pulsation in the hand, also some get in the feet also. So also in the femoral artery. So there is a different places we will get actually getting different types of peripheral signs. So these are the peripheral signs usually we get in a patient suffering from aortic regurgitation. So now this is another question. A 65 years old man presents with a 4-week history of general malaise and lethargy. He has had 2 courses of antibiotics that have temporarily improved his symptoms, but he continues to feel worse over time. His family physician notices he has become anemic. He attends the emergency department and he is admitted to hospital with a fever. So the cardinal features of this patient suffering from fever actually. And he has some blood culture taken. He undergoes an echocardiogram, which shows a mass on his mitral valve. So mitral valve mass, a patient having mitral valve on the echocardiogram, and he is suffering from low-grade fever over the 4-week history, and patient having some general malaise and lethargy. This patient may be features of the infective endocarditis. So diagnosis, likely this patient is suffering from infective endocarditis. What is the most likely organism that will be grown from his blood culture? There are some organisms listed here like Staphylococcus aureus, Staphylococcus epidermidis, Staphylococcus faecalis, Staphylococcus galacticus, and Viridans Staphylococcus. So Viridans Staphylococcus actually is the most common organism, Staphylococcus actually Viridans, that usually cause the infective endocarditis. So we'll see here some common organism that can infect the valves or endocardium of the heart and causing the infective endocarditis. So this is the common bacteria are Staphylococcus like Viridans or Staphylococcus mitis or Staphylococcus sanguis. Actually, they are called subacute endocarditis, as this patient has got fever for the long period. over the 4 weeks. So this may be a subacute cause. So in that cases, usually we see the organism is the low virulence organism like Streptococcus viridans. Even Enterococca can also cause subacute, and there may coagulous negative Staphylococcus, prosthetic heart valves may affect, and coagulous negative Staphylococcus may causing fulminant endocarditis also. So less common bacteria are aureus, hemolytic Staphylococcus pneumoniae, and there are some uncommon organisms like fungus or pseudomonas or hatchet group of organism. So these are the organism actually that causes the infective endocarditis, but among them Streptococcus viridans is the most common organism that usually affect the native valves. And there are some endocarditis bacterial source, abnormal source, and bacterial source which will cause Streptococcus viridans or Streptococcus bovis. That is Streptococcus group are the most common, but in some cases Staphylococcus and also causes the infective endocarditis. So this is the another answer. So considering the patient in last questions, before the blood cast alerts are known, the junior doctor reviews the 65-year-old man and examines him for evidence of Streptococcus. So as the patient got mass in the mitral valve during echocardiography, so meticulously the physician actually examined the patients to find out the other features of endocarditis. So what is the most common sign that doctor is likely to find? Hematuria, osseous node, Ross spots, splinter hemorrhage, subconjunctival hemorrhage. So among these 5 features, if we see the next slides, that is patient may have a lot of features in physical examination like PTK, splinter hemorrhage, osseous node, generations, Ross sports. And this is the actually modified Duke criteria for a definite possible and rejected diagnosis of endocarditis actually. And this is the actually percentage physical findings that usually we encounter and this is the with percentage usually this is the described here. These heart murmurs usually found in 89% cases. Fever is present in 77% cases. Embolic events, that's 50% cases there is some embolic events. There is some skin manifestation like genital lesion and other lesions. Splinter hemorrhage genital lesion that is usually seen skin manifestation. Maybe splenomegaly in 28% cases. Septic complication 19% cases. Mycotic aneurysm 18% cases. Glomerulonephritis between that is hematuria usually we get in lower percentage actually. Digital claving, retinal lesion usually get in low percentage. So this is the Ross sports means retinal lesion usually get in low percentage, and hematuria also you get a low percentage. Osseous node that maybe we found in the hand, and there is a splinter hemorrhage and subconjunctival hemorrhage. These are the eye features and skin features. So eye features, skin features are the common here. Skin manifestation around the 50% and embolic events around the 50%. So this osseous node, this is the actually features of embolic event, and more or less these are the some features of embolic events are actually some features are due to glomerulonephritis. So this is another question here. You review a 25-year-old woman who has recently been diagnosed as having long QT syndrome type 1. This is actually something about the long QT syndrome. You are discussing the need to avoid certain drugs or other aggravating factors. Which one of the following should be avoided if possible? Methotrexate, sertraline, grapefruit juice, carbamazepine, and doxycycline. So we have to find out which drug actually causes prolongation of the QT, as this patient is suffering from long QT syndrome. And if we give some drugs that can cause the long QT, and with this long QT syndrome, this patient, if we use this the drugs that causes also long QT syndrome, so there may be further prolongation of the long QT, and that may predispose to the development of the actually ventricular fibrillations, and ventricular fibrillation may occur. So we have to next see which drug can cause long QT syndrome. That is, there are some common drugs to avoid in patients with long QT syndrome. There are some cardiac drugs like sotalol, quinidine, and amiodarone. There are some psychiatric drugs like haloperidol, fluoxetine, and sertraline. There are some antibiotics like azithromycin, clarithromycin, and ciprofloxacin group of drugs. There are some narcotics drugs like methadone. So we already get the answer. There is a sertraline is a antipsychotic drug, that is psychiatric drug, and that is a tetracycline antidepressant drug, and actually the tricyclic antidepressant or tetracyclic antidepressant drug that can cause the long QT syndrome. So we always avoid the drug when a patient has got long QT syndrome, either in the congenital or acquired. So we have to avoid this group of drugs like amiodarone, sertraline, fluoxetine, haloperidol. We have to be avoid. So the answer is here B. This sertraline is the exact answer here. That is, if a patient suffering has got a congenital long QT syndrome, he or she should avoid the sertraline group of drugs. That is tetracycline or tricycline antidepressants or other macrolides also to be avoided, and some other cardiac drugs like amiodarone or sotalol that is commonly used in different types of arrhythmia. So these drugs also should be avoided if a patient has got long QT syndrome. So I think we can stop here today. In the next class, inshallah, 7th class, we can discuss several questions also. Probably that will be the next Tuesday. So good night to you all, and have a safe day also. So thank you very much for patient hearing. So I think this is the end here. If you have any questions, you can put in the Facebook Live or Facebook, and we'll try to give the answers later on. So thank you very much for being with me for around 45 minutes. So good night today.